Thank you for joining us for our webinar series, Unlocking Hormonal Health, Proven Strategies for Practitioners. The presentation will begin in a moment. The presentation will begin in a moment.
Hi, everyone. Welcome. Welcome. Thank you all for being here. My name is Dr. Patti Devers, and I am the Chief Clinical Officer here at Genova Diagnostics. And Genova is honored to have sponsored this bootcamp over the past several weeks entitled Unlocking Hormonal Health with these amazing speakers, Dr. Pam Smith, Dr. Christopher Mote, and our very own Michael Chapman. So thank you all for coming back and reconvening to have this panel discussion and to answer some of the questions that have come through. I'll tell you, I know that these people have been watching these videos with rapt attention and taking copious notes because we've received tons of email of questions that they'd like to ask you. It's their chance to interact with key opinion leaders in the hormone space. So thank you so much for agreeing to do this and kind of close the loop on some of the concepts that they maybe need a little bit deeper insight into. So thank you so much for joining us today. I'm going to start with Dr. Smith. We know that you've got tons of experience in this space. I mean, you've been around a long time and are considered a true mentor to many of us within this space who are clinicians. What would you say is one of the most common confusions or mistakes that doctors who are new to bioidentical hormone replacement therapy make? What are the biggest mistakes or confusions that you see?
I think part of the confusion really is a couple-fold. Number one, they don't realize that it does matter if it is bioidentical hormones, because it does. Mm-hmm. And they also do not realize a lot about testing. Testing is so key. Some practitioners do not test at all, which to me is crazy because you don't give thyroid medicine without measuring thyroid. So of course you would measure the sex hormones if you're going to give them. They also really don't understand testing. So if it's okay with you, I'd like to take a minute or so to explain testing. Is that okay?
Sure.
Okay, great. So when we look at serum testing, we measure pregnenolone by serum. But when we measure by saliva, we actually get the bioavailable hormone. How much is available for the body to use at that time? By serum, we cannot get bioavailable progesterone. So we would lack that knowledge. Also, the steroid hormones are so lipophilic that they literally go into the tissues very, very quickly. And they studied testosterone. When you use testosterone, it goes directly into the tissues, so it only stays in the serum for 12 minutes. 12 minutes. So you really can't measure it. When you put something on the skin, it just does not show up in the blood. And most practitioners do not realize that. A lot of them use serum testing. They also don't realize the studies that were done on cortisol. Cortisol, the gold standard for anybody, for all practitioners in the world, is salivary testing. There are 6 clinical trials showing that. And this new vogue now is to measure hormones by urine. Believe me, I do urine testing. I want to look at 2, 4, and 16 hydroxyestrogen. I want to do a 24-hour urine and look at all of the hormones, oligopregnanolone, etc. But I don't dose off of urine because it's a metabolite. It's not the direct measurement of the hormone. It literally is basically a metabolite or breakdown product. And how I metabolize things, and everybody today metabolizes them, is entirely different for many different reasons. They published a trial in menopause in November of 2023, suggested urine testing, and the dose that they had to use of estradiol in the urine to achieve an actual result was the dose that would actually cause heart disease instead of prevent heart disease in women, according to a 2019 study. So I actually wrote a rebuttal to that article, which is being published in April this month in Menopause, because we don't want to cause disease, we want to prevent disease. So I think that's really probably, if I could choose one thing, the biggest issue is that people either don't measure or they don't know how to measure the hormones. And very important, we do measure them 90 days after we give hormones and every 6 months thereafter.
Awesome. Greatly appreciate that. So it's a little masterclass in testing, which is awesome. I next want to go Dr. Mote. So Dr. Mote, this is the Endo Plus report. You'll see on the front page here, we have this little pyramid graphic, as you'll remember, with the HPA axis kind of near the base of this triangle, indicating how it impacts thyroid and sex hormones. How often do you see thyroid and sex hormone imbalances improve just by optimizing the HPA axis? How often do you see that?
Well, so you're setting me up because that's my wheelhouse. I started as a chiropractor before I went to medical school. And without prescribing rights, it really forces you to really walk the patient through the lifestyle levers that they need to pull if they're really going to balance hormones. And it was in 2002 when the National Institutes of Health concluded that study and published it. And I had my own little chiropractic office sitting in Barrington, Illinois. And underneath the door was the Time magazine and the Newsweek magazine. Splashed on the cover was, just how dangerous these hormones were. And so as a chiropractor, looking at it very simplistic, I'm like, right, let's open the doors because people are coming in and they'd already flushed all their hormones and now they don't know what to do. And so many miserable ladies, and we brought them in and we helped them understand that if you will modify for modifiable stress factors, that your own nervous system can do a better job of balancing hormones than I could do if I had a prescribing pad. Now, obviously, it helps to do that, but we get better results. Two reasons why. One, we focus on the HPA axis and the limbic system that drives it, but now that I went back to medical school, it is nice to have the bioidentical prescribing rights to go with it. So yes, we'll correlate the thyroid. We can see the T4 that doesn't convert to T3 when you have a limbic response and that cortisol that's high. We can also correlate that with secretory IgA and saliva now with your Endo Plus, and we can see how the limbic system and the cortisol rise is driving down your secretory IgA and all mucosal surfaces. So now you've got heavy antigen loads, and it really just dovetails through all of our program when you see that HPA axis through the cortisol awakening response.
Love that. And we're going to hit on some of those topics later in this panel discussion because it did come up in some of the questions that we received. So thank you so much for that, Dr. Mote. And I will also say, this Endo Plus report is beautiful. And I want to congratulate Michael because this is kind of Michael's baby. He created this report. So well done. And with that, on this front page, to piggyback on what Dr. Mote was just saying, we see this need for HPA axis support pillar on the front page. And one of the biomarkers within that pillar is the cortisol curve. Mm-hmm. So Michael, maybe you can talk to us about the significance of the cortisol curve on that front page pillar.
Yeah, absolutely. And thank you for providing the props. I didn't know you'd have props. So well done, Patti, for that. The cortisol curve, well, I think one of the things that we wanted to make sure that we included as part of the evaluation was the understanding that, really one of the main powers is not just is cortisol elevated or deficient, and at what time of day is it elevated or deficient, but what is the degree of that natural circadian rhythm of the decrease of cortisol throughout the day. We can talk a little bit, and if you remember, Patti, back, we talked, kind of like phase 1, phase 2, phase 3, kind of these older models for HPA axis dysfunction that were, I think to a certain degree provide you some insight, but we might agree also that it's a little bit simplistic, a little bit reductionistic, and everyone's a little bit different in how they manifest cortisol dysfunction. But at the end of the day, we do want to make sure that from that morning cortisol to maybe that midday cortisol and throughout the rest of the day, there are kind of these predictable restitutions of the cortisol level. And one of the things that we've seen in the literature is maybe one of the greatest risks is actually the flat cortisol diurnal pattern. And that was the one that tends to be most associated with even things like cancer risk, cardiovascular disease risk. And so not only did we want to make sure that people were not kind of hypercortisol or cortisol deficient, but that curve should be following kind of a predictable pattern. And so we're also including that as part of the assessment on that front page for HPA axis function.
Yeah, that's important. Not just the levels, but what's happening with the curve is very important. Dr. Smith, within your case presentations, in your slides and in your presentation, you mentioned in one of those case studies, a patient had positive thyroid antibodies, anti-TPO or anti-TG. And within the follow-up, you suggested a stool test. Can you kind of close the loop and make the connection there between why you would get a stool test and follow up to having anti-thyroid antibodies?
Absolutely. When we look at autoimmune diseases, of which positive thyroid antibodies would be an autoimmune disease, looking at Hashimoto's thyroiditis, which is what I was discussing, or if you're even looking at Graves', we always do three things with any autoimmune disease. It doesn't matter what they are, including Hashimoto's and Graves'. Number one, we take the patient off of gluten. Number two, we do a GI effects test to determine really what is going on in the gut, because 70% of the immune system is in the GI tract. So you have to know what's going on. You know, I love talking about hormones, but in all honesty, I really razz people. If you ask me, are hormones more important or is the gut more important? My response is they're equal. You have to have both to have a healthy patient, because as you can see, when you look at the cortisol response curve, one of the things that can cause an abnormal cortisol level is leaky gut syndrome. And if cortisol remains abnormal, it can actually cause a gut to be abnormal. So the three things: number one, take the patient off of gluten; two, do the GI effects test; then the third would be low dose naltrexone to decrease the inflammatory response that occurs with autoimmune diseases like Hashimoto's and Graves'.
Yeah, it's constantly missed in patients with autoimmune disease, the importance of the GI tract. So love that you had that in your slide. So that's great. I'm going to switch gears just a bit, Dr. Mote. Let's talk a bit about progesterone. You know, Michael and I have some interesting discussions, and even within our department here, we have a lot of discussions about the connection between progesterone and sleep. Can you speak a little bit about how you might use various patterns on the Endo Plus that are related to poor quality sleep? So it's not just progesterone. What are you looking for within a hormonal balance to speak to the sleep question?
Yeah, there's 4 key markers on your Endo Plus that I use for sleep. And sleep is one of the first things we try to establish in every patient with chronic illness, whether you're having to treat an autoimmune condition, as she was referring to, and the T cell dysfunction that comes with poor sleep. So we look at the cortisol awakening response. And the reason I say that is that not only can you pick up the limbic response that's driving higher cortisol and higher stress through the patient's nervous system through the day, but if the first morning cortisol is elevated, you probably have sleep apnea or some other significant stressor going on in their sleep. The second one we look at is bedtime cortisol, because that will blunt the release of growth hormone and cut short your deep and REM sleep. If you have a patient with a sleep tracker, they can see that. And we'll use phosphatidylserine to lower that. And then, of course, melatonin. We see more circadian disruption there than we actually see deficits in melatonin. And then you mentioned the progesterone, because early in my career, my mentor shared with me that progesterone is good for both genders because it opens the receptors, the GABA receptors. And so I found that to be the case before I had prescribing rights. I was using a lot of GABA, but I got modest benefit for patients at best. But as soon as we see low progesterone and give 100 milligrams of micronized bioidentical progesterone before bed, sleep for many patients became something that was something they welcomed instead of something they dreaded. It's just so powerful to calm the mind.
Awesome. Awesome. And I've had that experience myself, had recently been put on progesterone, which has profoundly changed my life. So I appreciate that greatly. And like we said earlier, Michael, this Endo Plus profile is the first of its kind, where clinicians can have the option to see sex hormones in saliva, serum, and urine at the same time. But with that, we've learned a lot. And, you know, Dr. Smith and Dr. Mote can attest, when you start to see these things come through, we're learning on the fly, like how different things are measured. And Michael and I have had this discussion. I think, Pam, you just talked about this a little earlier, that we're actually measuring different things. So we're seeing discrepancies that aren't exactly discrepancies. So Michael, let's just talk a bit about this, because we've spent a lot of time on this as well. Is it possible, for example, with progesterone, on the heels of what Dr. Mote just said, is it possible to have like a low progesterone in your serum and then a high progesterone in your saliva? Like, what are the reasons for those not exactly discrepancies?
Yeah, and Patty, I think you kind of said a little bit of the answer too, is the aspect of how much we're kind of learning, because this amount of data to where we're seeing actually results side by side, where people were literally doing their saliva, their serum, their urine testing at the same time, is not something that we've really have a lot of literature currently to hang our hat on to compare these and create some of the mechanisms. I would say the example that you were just stating around whether somebody could potentially have higher levels in saliva and moderate levels in serum, one of the things that we tend to think of is whether how much of that topically applied hormone is actually going to tissue sites. What's the pharmacodynamics of that hormone, meaning where is it going and being distributed and in what concentrations? Dr. Smith was just mentioning that most of the topical applications could be going directly to the target tissues and into the tissue space, leaving a whole lot or a whole little to circulate in the serum. And interestingly, Patty, as you know, we've also seen some studies that demonstrate that if you take patients and you compare their salivary levels to their dried blood spot levels, you tend to see that while people are very consistent across time, some people will secrete a high amount of saliva or a high amount of hormone into their saliva as compared to others, which, as we know in personalized medicine, like everyone is kind of different. So I think that might explain some of these times where we get back results that look pretty wild from a salivary perspective, things that are 10, 20 times reference range. But again, we have a small N number to start to compare this. And this is one of the other things that we've been so crazy excited about at Genova to really start to develop the hypotheses to drive even more clinical insight. So, I think the next couple of years is going to be really exciting on the hormone front that way.
Yeah, I agree. And I kind of want to tie two of these concepts we've just been talking about together and just kind of open this up to the group with your clinical expertise. I think a lot of people don't really fully understand progesterone as it relates to stress. So we're going to tie those two things together. We've seen here in our department elevations in progesterone with the stress response, because we know progesterone is also produced in the adrenal cortex. There's a paper or two regarding this. How often have you seen this clinically in someone who has an elevated progesterone, that it's related more specifically to a stress response? Have you seen that?
Who do you want to take that one first?
Go for it, Dr. Mote.
Okay. Yeah, I would agree with that. When we see an elevated cortisol awakening response, especially, that'll clue in. But you can even trace that further up the steroid hormone synthesis pathway to LDL cholesterol and total cholesterol. So we'll see a lot of patients come in with their standard lipid profile having a normal HDL and a normal triglyceride, and so relatively low risk for heart disease. But you'll see an elevated total and an elevated LDL that looks ugly, and so both they and their primary care doctor are overly concerned about it. And then you can trace that right along, and you'll see that elevated progesterone and that elevated cortisol, with the upregulation of the synthesis of LDL cholesterol in the liver during a stress response. Absolutely.
And that's important because, some clinicians would see a high progesterone, start lowering doses of hormones instead of getting to that root cause. So I think that's really important. Have you seen that as well, Dr. Smith?
One more thing. There's such a variability too, especially in women. If you sample that progesterone and you do it again 2 days later, it could be dramatically different. So it is certainly a highly variable hormone.
Important.
And to add to that, because I agree with everything that's been said so far, but remember when we give progesterone PO, most prescribers give E4M, otherwise known as sustained release. So if the gut's not healthy, then we're going to get variable absorption of the hormone that's going to be given to begin with. So that affects it. Progesterone and cortisol share receptor sites. And so the patient stays really stressed all the time. The amount of progesterone that actually binds can be quite variable. And also the breakdown products. If you look at them, some people really have an issue with GABA and some of the other neurotransmitters where it negatively impacts allopregnanolone, which then really affects progesterone and how people really metabolize it and also how they handle it. They may actually get a too stimulatory effect with allopregnanolone when it changes. So all of these literally affect what happens when progesterone's given in its relationship to cortisol.
And Michael, you and I had this discussion on our podcast about how progesterone is bound in the serum to corticosteroid binding globulin. So there's still that direct connection as well. I mean, you talk to clinicians all the time, Michael. So what's your experience with that?
Yeah, I would actually, one of the things that I love sometimes in studying the mechanics, I guess the mechanisms of these things is that it really does kind of make sense that under a degree of stress, knowing that cortisol is a downstream product of progesterone, that there would be a feedback mechanism driving greater production of progesterone in that case. And one of the things that I've a little bit of, I guess, a hole in my knowledge was around how cholesterol and zoosterols actually turned into progesterone and what some of those elements were that drive that. And so that's actually a part of cell membrane and mitochondrial aspect that is responsible for that conversion of cholesterol into progesterone. And so while stress might be upregulating that conversion, we also have to think too about how things like alcohol, poor lifestyle factors, and just generally mitochondrial dysfunction can actually overshoot that and imbalance that on the other side. So it demonstrates how complex the system is, to where, maybe even in the case of somebody who's high stress that has a normal progesterone, you could not be seeing that feedback mechanism show up because they have mitochondrial dysfunction, right? And so it's so fascinating to see these things come together from a mechanistic standpoint. And that's when I get all giddy, I guess.
We're really seeing this with long haul COVID. And some studies suggest that 50% of people that have gotten COVID get long haul, which in my personal opinion is a mitochondrial disorder. It also is a disorder that occurs with cortisol and can negatively impact thyroid. And there's a relationship between all of those. So if you don't go back and refuel the mitochondria, then you really have a hard time getting all these different pathways to work appropriately. So in case anybody out there is interested in refueling the mitochondria, and that occurs if you have a high reverse T3 as well. I did talk about it in the seminar, but let me reiterate. The T3, reverse T3 is elevated. One of the main reasons is mitochondrial dysfunction, where you can't get thyroid hormone into the cell because it is a conductor of the hormonal symphony. None of this works right, cortisol or anything else. So we want to make sure that we use magnesium, 400 to 600 milligrams of glycinate or threonate, that we use D-ribose, 15 grams to 30 grams, that we use both Q10 and alpha lipoic acid at about 300 to 400 milligrams. If the person has a normal TMAO, L-carnitine, and normal renal function at 2,000 milligrams a day works very well. There's some other nutrients you can add into that, but certainly refueling the mitochondria is helpful in these situations as well.
Love that. And you're right, hormones are complicated. Nothing works in isolation. But Dr. Mote, I want to go back to something you talked about earlier and really kind of hit this, because we get this question a lot. One of the new features on the EndoPlus is the ability to add on that salivary IgA. And most of us think of IgA as fecal secretory IgA in the GI tract as it relates to mucosal irritation or barrier dysfunction. But when it comes to salivary IgA, we're looking at this more of a marker of stress or impact on the immune system. So in your practice, when do you add on a salivary IgA, and what circumstances and what clinical presentations? Like, when are you using this biomarker, or is it for everyone?
Yeah, no, I use it as often as I can possibly get it, because it's so variable. You're getting a snapshot of the immune response as directed by the HPA axis. The secretory compartment in mucosal immunology, there's not a lot written on this, but going back a long time, I was taught that the mucosal immune system should be treated like a circulating immune system. That while you may not have direct communication between, say, vaginal tissue and the nasal passage, you can measure mucosal, you can measure fluids and the secretory IgA in both compartments, and they should be tracking together up and down as you do serial measurements. So we like it that when we get it on the stool test, and it's really not super helpful unless it's markedly elevated or particularly flat. But when you get your second stool test and you're still working with a patient who's complaining of gut problems, and now you got your third, and then you start to see it, and now you look at the patient and say, every one of your secretory IgAs has been low. There's a stress component here that we are not addressing, or that you haven't addressed yet as a patient. And now that we can add it to the salivary testing that we're doing, we should be able to be getting one up maybe as much as every 3 to 4 months and show them the trend. Because I just think if I had 2 markers to manage patients that would really motivate their desire for change, it'd be the cortisol awakening response, and it'd be a secretory IgA. Because that is, again, the gateway to antigen penetration. And if you can't shut that off, then you're going to have a perpetually antigen-heavy patient who's chronically inflamed. So,
Wow, that's super important. Michael, I've heard you rant about reference ranges. This is one of your famous arguments here. I've heard you say, not only in these presentations, but in other presentations at other conferences. And your famous line is, a lab is only as good as its reference range, right? And you drive home the importance of reference range. I mean, we work for a laboratory, so we understand. I didn't fully understand laboratory medicine before I started here. And to your point, people don't often pay attention to where the reference range comes from. So there are some companies who create reference ranges for hormones on patients taking very specific bioidentical hormone replacement therapy. What's the benefit of that, or the drawbacks of that, versus just picking a healthy cohort with all comers like Genova's? Can you speak a little bit to reference ranges?
Sure. Yeah. And it'll be great to go down in history as the person who rants on reference ranges. That's a big claim to fame. But what
Important.
I guess, so pros and cons, I wouldn't say that necessarily one approach to reference range creation is better than another in any sort of way, but I do think it's important to try to understand the differences so you know basically what a result means. If you don't understand kind of what that reference range came from, then it's hard to really actually know what that what the result of the patient result means. And so I think commonly reference ranges, we're most familiar with reference ranges that are oftentimes population based, meaning that there's a certain N number, and preferably a large N number, to get a really nice standard bell curve. And so when I think about this, I think about something like TSH. And TSH, from a standard conventional approach, we all probably know if you go to a certain lab, you might have a reference range of, say, greater than 5. But if you've been studying functional medicine for a minute, you might say to yourself, that seems pretty darn wide for a TSH. And that's likely because the population study, right? If you have a large number of people, you're not necessarily doing a very significant screen for healthy versus unhealthy people. And whereas compared to a lot of what we try to do at Genova in setting a reference range is we try to have a very rigorous screen up front to essentially exclude a lot of people who might be considered unhealthy because of whether their dietary patterns or their exercise or their activity levels and things of that nature, certainly screening against chronic conditions, because really if we're a lab test is basically a comparison at the end of the day. And so we want to know who we're comparing to. And so from our reference ranges, most of them are healthy, control, questionnaire qualified, and excluded based reference ranges. That means that the comparison is to healthy people, right? People who are doing very well with their overall health. And that means at the end of the day, sometimes those reference ranges tend to be a little bit narrower, right? But that gives you a different type of comparison to, say, a population-based assessment.
Yeah. And even some of the reference ranges based on people taking very specific bioidentical hormone replacement therapy, there's no insight into how they're clinically feeling or what they're doing. So it always comes back to the questionnaire qualifiers. And I don't want to be like everyone else. I want to be optimal. I want to be better than everybody else. It's kind of our feel about it. And I think, Pam, this is going to take us into some of our age-old clinical pearls in your years of teaching and mentoring clinicians. They decide they're going to start someone on bioidentical hormone replacement therapy. How in the world do you know where to start? Like, what dose do you pick? You just pick a random dose and hope for the best. Where do you start if you want to put someone on something like progesterone, for example?
Well, literally in all these years, which I can't believe it's my 47th year of practice, but it
Wow.
is.
Wow. Congrats.
When I really look at it, I've looked at 80,000 saliva tests. And so I've looked at a lot of them. And so I'm actually now teaching a course at the Morsana College of Medicine at the University of South Florida in personalized medicine. It's a certification. First course is endocrinology. And actually we discussed this. We literally discuss where would you start if you got these reference ranges, where would you begin? And for me, I've mathematically figured it out looking at this many tests. And so I have a mathematical range that I use, and it's accurate to about 87% of patients. You're right, it's not accurate for every patient, but you have to start somewhere. And so I do start there. And then we repeat in 90 days and every 6 months thereafter. I think it's really important that people understand that. A lot of people think, oh, you can just do it once and that's it. It does take the hormones 90 days to balance themselves. So you repeat the saliva test in 90 days and again, every 6 months for the rest of their life. That begs the question, how long would the patient stay on hormones? My personal opinion is forever. When you put me in the grave, my hormones are going in the box with me because I absolutely refuse to leave them. Anybody who's interested in the course, they can go to personalizedmedicinecertification.com. That's personalizedmedicinecertification.com. So that would be one way to start. Otherwise, my advice is always, and I know that all of you agree with this, you start low and go slow because you can always go upward. And also, it's all about balance. It really does matter if you balance estrogen with progesterone and estrogen with testosterone and DHEA with cortisol, and you get the conductor of the hormonal symphony of thyroid, which is why I'm so thrilled it's on the endo test and that cortisol is normal. It's all just right there in one test, which is really fabulous because really nowhere else can you find this information.
I'll tell you, that mantra is burned into our brains from having been trained by you, Dr. Smith. Like our whole team, start low, go slow. We say it all the time on the phone. It's burned into our memories because of you. So thank you for that. Dr. Mote, I want to dive a little bit deeper into the cortisol awakening response. I mean, this is kind of your specialty and it's so important and really misunderstood, I guess is the best way to say it. That initial pulsation of the cortisol as soon as you open your eyes in the morning. And we know that's currently an add-on to the EndoPlus test as well. You use this to great effect in your clinical practice, but I guess the question is, how do you use it? Like, does it change your therapeutics or hone in your therapeutics? Like, what does it do? What does it change for you with your patient?
When you consider that virtually every chronic illness has stress as the primary factor or an exacerbation, a cause for exacerbation, it becomes a big deal to understand the stress response. And you can't understand the stress response if you're just going to look at cortisol and assume it's the adrenal gland. That's the end product of the stress response that starts in the brain. And I just think this cortisol awakening response is such an economical way to monitor what's going on in the nervous system, specifically the limbic response. If you think about the limbic system, that feeling and reacting center in the brain, that started when we were still crawling around and didn't have executive function yet in our prefrontal cortex. It was listening to people's tones and facial gestures and body language, and it would tell us we're safe or we're not safe. And you can have three types of injuries to that system. The big T, traumas, physical and emotional injuries that don't heal, brain injuries, and then pervasive elevated psychological stress. All can leave you with elevated or accelerated limbic responses. And that's demonstrable in a cortisol awakening response. It correlates. So when we see the typical 30 to 130% rise in that second cortisol awakening response, we congratulate the patient and say, your brain is able to mount the appropriate stress response. Now, you just have to control your stress. But when we see the exaggerated stress response, we like the term chronic threat response, because the brain wakes up in the morning and everything is a perceived threat. And so it's rippling through not only the nervous system, but all the hormone systems that we've been talking about, the adrenal axis, the thyroid axis, the gonadal axis. And then it also affects gut, both motility and the secretory IgA that we're referring to. And if that limbic system is allowed to remain the primary driver, you will deplete the brain chemistry. And that's where the cortisol awakening response was compared to biopsies of mice to see the depleted dopamine and serotonin, GABA, and glutamate in the flat cortisol awakening response. What's interesting is when you start to improve the patient's health through their lifestyle change, the elimination of inflammation from the gut, you'll go from a flat cortisol awakening response and can actually 3 to 4 months later get into an exaggerated or that chronic threat response. And now you know you're also dealing with the limbic system, and you might have to go back and do things, whether it's limbic retraining and the neuroplasticity programs that Gupta and Annie Hopper have and some of the others. But that's such a fantastic test to see the driver of poor health coming through the nervous system and to help a patient see that they've got to address it.
I was so glad to see that it was an add-on because, you know, all of us have so much to learn, myself included. And honestly, it wasn't until recently, and it's from really all of your work, that I have discovered how important the cortisol awakening response is in depression and anxiety. That really has become recently, to me, something that I have really honed in on and learned. And it's really helped me help patients a whole lot more. So thank you for doing all this research and helping me, because I'm getting better at those patients that have anxiety and depression.
Agree. And we're all still learning, I guess, which is why a panel discussion like this is so important. It's so helpful to people. I'm going to open this up just kind of like to the group, because we haven't really talked about hormone detoxification yet and the downstream metabolism of hormones, which is where we use the urine for it. To what Dr. Smith had said earlier, we look in the urine for the downstream metabolism to make sure that patients are taking the correct pathway and not a risk increasing way. So detoxification is important, and it's measured in the urine on the EndoPlus. What are some of your go-to strategies to improve hormone detoxification? I also want to put a plug in for stool test and beta-glucuronidase, but what are some of your strategies to help optimize estrogen metabolism? I'm going to open that up to everyone. Or not. Dr. Mote's like,
well, I'm just going to go to the basics. Phase 1, phase 2, phase 3 detoxification, because about 75% of estrogen, for example, is cleared through the liver. So you have to do phase 1, phase 2. The other 25% is cleared through the GI tract. So you need to do phase 3. So when people come in to me with estrogen excess or estrogen dominance, whether it's they have it themselves or it's caused by the fact they were given too much estrogen by a prescriber who doesn't do this kind of testing, they really need to have more education in this area. I go through phase 1, phase 2, and phase 3 detoxification.
There you go.
Yeah, I would think about too, what the products that are created out of those things, right? So if you think back to phase 1, the act of going through detoxification in phase 1 actually creates that intermediate molecule that's very unstable, more unstable even than the original analyte or the chemical. And so in that circumstance, I'm thinking about all our amazing antioxidants that we have from our foods, you know, everything that has a high ORAC value, right? Everything with a lot of deep reds, purples, our berries, cherries, things like that. Very high in sort of mitigating free radicals that are produced during phase 1. And then phase 2 are our conjugators. So that's where I'm thinking about making sure we support things like glutathione, and you do that with things like NAC, and glycine is another one for me that I really like to use for glutathione support. Certainly making sure we have adequate cofactors to produce it, such as we're thinking magnesium and B6 are important in producing glutathione as well. And so those are kind of the food-based, or at least the basic nutrient elements that I would add to make sure we're supporting those things.
Well, and that's what I love about the methylation test, because I do it on almost every single patient. I love the fact that I look at methylation and get the whole pathway, but then it goes into transsulfuration. And as you all know, one side of that is glutathione. And my patients are so surprised and they go, oh my gosh, I need glutathione. And you've kind of gently said to them before, but now that they see it on the test and they realize, oh my gosh, it's the end product of a pathway. I really need the whole pathway to work for myself.
Yeah. Dr. Mote, you want to weigh in?
Yeah, I'll just throw in there that I really like that you're including the genomics with that test as an add-on. While I get a NutriVal and put my genomics on that one, we have some people that come through and would like to see their hormones, and I would love to be able to add on, especially the COMT. If you're going to talk about detoxification, the catechol-methyltransferase, when it's a homozygous mutation, then you know you're going to have trouble not just with getting rid of estrogen, but all of the toxins that we talk about, whether it's mycotoxins, et cetera. So to me, that's a big part of it. But I agree with everything else I heard.
Yeah, that's great. Great. And speaking of metabolism, we were just talking about estrogen metabolism. Michael, when you created this report, that pyramid on the front page, the bottom says metabolism, but we've discussed that this is not, you're not referring to estrogen metabolism within that pyramid. You're talking about systemic metabolism.
Mm-hmm.
So can you speak to how perhaps a person's metabolism can affect hormone balance?
Yeah, I mean, it's a pyramid, that was not necessarily anything that we, thought up ourselves. As something we've seen pretty well established as far as at least a general representation of maybe how these hormones interact. And as we're learning about metabolic health and metabolic dysfunction more and more every single year, as it really is not just potentially the base of the pyramid of kind of the endocrine communication aspect, but really the base of so many chronic diseases in and of themselves, and just the importance therein. It seemed relevant to make sure that something as significant as insulin was represented, even if it wasn't an analyte yet on this report. But yeah, we certainly know that a lot of times, if you're thinking about the hormone cascade, there's very simple connections between metabolic dysfunction, such as the aromatase enzyme would be one, I guess, where high expression of aromatase has been shown in adipose tissue. So the more adiposity you have, then you're going to have an upregulation of that aromatase, which ultimately can turn our androgens like testosterone into higher amounts of estrone and estradiol. So that's just one kind of simple component there. But I would also say, maybe from a greater perspective, we've seen a lot of research around how insulin resistance and metabolic dysfunction impacts things like sex hormone binding globulin, which does control the balance between bound and unbound hormone in the system, and the degree to which that might influence even our receptor sensitivity around our androgens and estrogens and the rest of our hormones. All of those things just kind of demonstrates how connected really these systems are. And even from I guess a macroscopic perspective, what you tend to see is just the general dysregulation that occurs when metabolism and our energy systems are so off balance to where you don't have metabolic flexibility. And it makes sense, because metabolic dysfunction is, at the end of the day, a problem with the cells being able to produce energy. And no wonder they might be sending off panic signals that ultimately is going to affect all of our things like fertility and whatnot down the road. So it even makes sense kind of just from a general complex systems perspective, I guess.
Well, even when you look at the deiodinases related to thyroid and their function, it still affects that as well, all three of them. So
Right.
It is fascinating on how it's all tied together.
Right. Excellent point. And you talked about it earlier with long COVID and metabolic health and how it relates to hormones. So that all makes perfect sense. I just want to ask Dr. Mote specifically about testing hormones. Like, Pam talked a little bit earlier about, the importance of testing. Michael talked about the different matrices, but when you have a patient in front of you who's, for example, on bioidentical hormone replacement therapy, some clinicians have their own protocol of when they want a patient to test. Do you test at the nadir, like before they're about to take their dose the next morning? Or do you have people take their dose of whatever and then test? And it also affects things like, if someone's on a troche, you're not going to then do a salivary test. But do you have specific rules around testing that you prefer to see with your patients?
I do. So in the past, we've used the menopause profile when we just wanted to check sex hormones. And now I like that we can get one test and we can just check the boxes we want. So thank you for that, Michael. No, I try to help patients understand that the only real variations we have in our testing protocol is, do you want to see your endogenous hormones, what you make for yourself, absence any hormone therapy, or do you recognize, like Dr. Smith said, that it's probably a good idea to be on these long term, and let's see if the therapy is actually appropriate. Are we in good physiologic ranges? And that's really the only decision we have, because honestly, even the bioidentical micronized progesterone is not cleared from the system so quickly that we have to pick a certain time of day. That's not my understanding. And if I'm wrong, then I'm happy to hear that. But really what we're looking at on this EndoPlus, when you put the cortisol awakening response, the sex hormones, certainly melatonin, these are patterns that the brain maintains. So like the directions say, unless this is a highly unusual day, and if it is, rinse out your tubes and let them dry and spit again another day. You're looking at patterns that are established in the brain. And so, like Dr. Smith said, we want you on your hormone therapy for 90 days so the brain gets to see and organize the physiologic events of a woman's cycle, for example, with the benefit of the higher level of hormone. And so we also don't ask women on low dose of progesterone who are still menstruating to necessarily stop that. We would say within 2 cycles, if you're on something as low as 100 milligrams, your hypothalamus is going to reorder those timing of the events, the ovulation, the menstruation, and you just have to ride that out. But you don't have to be so careful with the timing the doses. Now, I may not, everybody may not follow that, but that's where we've evolved.
I love that. Dr. Smith, you have a lot of patients on BHRT as well. Do you have specific instructions you give them on timing of testing, like to take their dose prior to testing?
I do, and I'd like to broaden my response if that's okay.
Absolutely.
I love the fact that Genova has many kinds of salivary tests. Because for me, when I see someone who's younger, if they have PMS, PMDD, infertility, PCOS, I love the 28-day test because I honestly believe that 11 days worth of sampling you really need to do to figure out where their hormones are because they're jumping around all over the place. I use the 6-day test for people that are perimenopausal for the same reason. The hormones are jumping up and down. And so the first day of that test, I do on day 16. So days 16, 18, 20, and 21. And then I use the 1-day test, obviously, for postmenopausal and for people that are ending up on hormones. When I look at the idea of when they should take the hormones, I look at the idea of progesterone. If it's PO, it's 12 hours before, so the night before. If the hormones otherwise, I look at it, they use it 24 hours before, and then they do the first morning saliva test and put their hormones on after that, after they do that too.
Yeah, it's something that we don't think about often, you know, here and when we're doing our testing, or as a clinician, you're handing a kit, but you're not really giving them what are you looking for and how can they dose appropriately. So that's really, really important. Well, we're almost at the top of the hour, but I want to do 2 things. First, I want to talk about something non-hormone related, though sort of hormone related. I want to talk about your practices and some really important education that you both do. I know, Dr. Mote, you have a really intriguing practice and a community model approach, and you have actually been on our podcast to talk about that. Can you talk just a little bit about the community model approach in your practice and how you think that's helpful?
Yeah. COVID taught us, we were already on this path, but COVID really drove it home that relationships are messy, but everybody needs them. They are so instrumental to maintaining your health. And some of the work that's being done out there by James Maskell, when he founded Heal Community and all the group health visits, our model is based around group health visits. And we have currently 12, and we're expanding those. But the most powerful group health visits are the ones that put people together and they come through as a cohort. And it's been proven that you don't have to dispense magical wisdom, just put them together and have them all excited about talking about health. And at the end of it, their biomarkers improve. So we have a primary care practice where we focus on functional medicine, but you can go back across the practice. And in both of those, we utilize group health visits extensively. It's good access to care. It's great patient education information. And the most important thing we have found in the process is that you bring people together and they get healthy.
Good connection. I love that.
Can I
Thank
ask a
you.
question about that
Yeah,
too?
go ahead.
I'm just wondering if there are clinicians out there who might be thinking, man, that sounds really cool, and I'd like to do that, but I'm just worried that no one's gonna buy in, or people aren't gonna show up, or things like that. Dr. Mote, do you have any sort of words of wisdom to at least demonstrate what your experience has been around that? That, I guess, is the natural fear that might have as a clinician thinking about starting up some community visits, is like, no one's going to show up.
Yes, we ran into that. And so we actually, so let me just say this. If I back one step further, when somebody calls up and says, I'd like to be a functional medicine patient in our office, we'd say, no, you can't. Until you come to our 1 hour free orientation. It's a live Zoom call that I give 3 times a month. We have 15 to 25 people that will jump on, and we set the expectations for how we do things in our practice. And we say, if you just don't think that's for you, well, we're sorry, but we've only had 5 people who's ever been through this in 8 years. That's over 3,000 patients came through our classes. 5 have ever said, yeah, I don't like that. I don't want to do that. So they're wonderfully popular, and when people actually get in, they love them. But we tell them, this is really how we do things, and you have to participate.
Awesome. Awesome.
That's what I say to my kids.
And like I said, we dove a bit deeper into the logistics of that on our podcast, the lab report. So check that out on iTunes or Spotify. But I also want to take 1 second again for Dr. Smith. I want you to walk through again this program that you're creating at Morsani. Could you give us that link and plug that one more time, please, for some of these people who want to dive a little bit deeper with you, and maybe perhaps even get 1/10 of the genius that they can try to be Pam Smith one day in their life. So please plug that program again for us.
Absolutely. Number one, this program really is for everybody. That's the unique thing about it. For the first time, a medical school is accepting everyone to its class. So you don't even have to be in healthcare. The first person who signed up was a full professor from Harvard.
Wow,
and
nice.
he basically is in the School of Business. And he signed up because he wanted to see what would happen if you set a different model like you have, okay, in your practice, and the different kind of models, so we can achieve better healthcare for people. So of course it's for physicians, but it's also for other kinds of physicians like naturopaths and chiropractors and dentists and other kinds of practitioners and PAs and nurse clinicians and nutritionists and acupuncturists. And it really is for everybody, because all patients deserve this kind of healthcare. So in order for all patients to receive it, we have to have all practitioners, pharmacists, everyone being able to have the same training. And so it's the only course of that kind in the entire world. And the first course is a mentorship with myself. And so literally you will be able to quote unquote rotate with me. You can email me. I've got a whole bunch of emails sitting in my box right now waiting for people to get me back. I saw a patient today that did this. I saw a patient today that did that. Because my goal, I will be 70 in July. My goal is to help everybody be really good at this. Plus, when I teach, I learn. So I learn from everybody as much as they impart to me as I impart to them. So personalized medicine certification.com. That's personalized medicine certification.com. The first class is being given twice this year. It's being given in Scottsdale in 2 weeks, and then in November in St. Petersburg, Florida. Courses 2 and 3 will be next year. There's 3 courses in order to get the certification. Really, honestly, you can't fail the course because there's no test. You need to come and take the course. The first course is in person. Courses 2 and 3 are hybrid, so you can do online or in person. You have to do at least 2 of the 15 webinars that we offer every year, and there's no exams. You write 2 case histories instead, because honestly, an exam only tells the dean and I that you can take a test. It doesn't tell us you know anything about a patient. So you write up 2 case histories, and If you need more information, we impart those to you, and really, we hope everybody decides to join so we can all get on the same page, whether we call it personalized, functional, any other term that we use for it, integrative. We just want the patients to be healthy, and they really need this kind of care.
Agree. I couldn't agree more. And again, I just want to thank you all for reconvening. I think we've curated most of the questions that people have. I just want the listeners to know that these videos will live on YouTube, on Genova's YouTube channel. So don't feel like you've missed anything. So you can watch these over and over and over and get all these little clinical nuggets. Thank you, Dr. Smith. Thank you, Dr. Mote. Thank you, Michael Chapman, for doing this. This is a success, this Unlocking Hormonal Health Bootcamp. Thank you so much for all of your time and effort and your expertise.
It's been a blast.
Thank you for this opportunity. And really, I'm serious. Thank you for creating the Endo Plus. I love the test.
Yeah, me
Go,
too.
Michael.
Have a good day, everybody.
All right.